I'll second.
Just like you're doing the TV show. 3.
You got it. You're on, sir. First order of business for the REMAC is the approval of minutes of the September 18th meeting.
No move.
Gotcha. Next order, the Downsville Agency restructures and has name change to Downsville Fire District and requests approval for provisional ALS status.
Yes, sir. I agree with it.
All right. There we go. The City of Johnstown Fire Department ambulance is seeking RSI approval and has submitted some paperwork which I sent in a timely manner to the REMAC physicians, and I turn the discussion over to them at this time on that issue.
Johnstown.
McCready was supposed to be here, but I worked with him on this, so if you have questions, I could probably answer them.
Who's your medical director?
Dr. Wakeman.
Gary?
Yep.
Any other questions? I guess time for a vote. Approve. No. No.
Everybody else should be here. You got it, sir.
Any discussion?
I would ask why we would deny that, why that would be denied.
I have not been in favor. I'd like to see some data on how we're doing in this region as far as RSI. I'd like how many RSAs are being accomplished, that we've got proof that there is medical director oversight and a good QA program, and then let's revisit this.
I think that Dr. Isanovsky spoke in regards to this last month, 2 months ago, when AMR went to that. So every one of our MFI cases, there's now only 2 agencies that are doing it, GAVAC and AMR.
So how many RSIs are being accomplished? Where's the data that says that we're doing the right thing? Where's the data that says that, okay, they're all being QI?
Dr. Isanovsky, our medical director, last month or 2 months ago, clearly stated that he reviews every one of our RSIs.
I personally send them to Dr. Isanovsky for review. And the reason we want to bring Johnstown on board is because it just creates another agency in the system. So when we have to put 2 rigs together, we can put 2 rigs together to accomplish the task. So with Johnstown, the city call needing an RSI, a GAVAC rig can come in and be the second credentialed person to do the RSI. Similarly, with GAVAC on the outskirts of Johnstown, Johnstown can come out and be the second credentialed person to do the RSI as well. Dr. Wakeman was given the packet that was created by the REMAC and AAREMS to review. He did review it. I spoke with him the other day. He happily signed the document, I think that you have. Dr. Wakeman is involved in the QA/QI process. He's part of EMS charts. He reviews every chart, actually, that Johnstown Fire handles. So I don't see, and to be quite honest with you, with the exception of 3 people in Johnstown, it's GAVAC people that have actually done RSI in the field that work for Johnstown part-time. So it's not like we're introducing new people to the process. It's people that have experience that work for Johnstown already.
Mickey, where are you transporting those patients to?
Wherever they need to go based on.
Are you flying them, or are you taking them to Albany Med, or you're taking them to Latour or
Yes.
St. Mary's?
Yes.
All of them. All right, so we need data on where they're going, because if they're going mainly to St. Mary's or Nathan Latour, you're 5 minutes from Nathan Latour in Johnstown. You know, we know that the better care is a hospital, not an ambulance.
Well, and we know that as well.
So,
So And we
Just
would-
because you intubate a patient doesn't mean that they can't go to a local hospital.
Right.
Right, but if you're taking them to Nathan Latour, how long are you staying on the scene to do the RSI versus putting them into the ambulance and going to Nathan Latour? That's the question.
It depends on the call. You
Right.
can't. you
So
can't
we
sit-
need the data.
You can't analyze every single call. It's just
Yeah,
dependent on what the situation is for
Right,
each
so
call.
the data needs to be there.
So, and I would say the majority of intubated patients go to a higher level of care anyways, so Ellis, Albany, or a fly-out.
Well, Ellis is not a trauma center anymore, so that would be
I'm
inappropriate.
not speaking of trauma, I can be talking about medical as well, so.
They're a stroke center, they're a
Yes,
cardiac
they are.
center.
Right.
I know that, and I know you're aware of that too.
Are we capable of getting follow-up on these patients?
From Albany, we get follow-up on the patients.
What about any other hospitals? How are we doing in the big,
If, in the local hospitals, we can get follow-up. Ellis is very, very difficult.
I guess I want to know that we're doing the right thing for the patient.
I would have to say that, I mean, based on my experience, we're doing the right thing for the patient. I mean, when we have, opportunities for
We're-
CPAP, we CPAP our patients when we possibly can CPAP them, when we can't CPAP them, when they can't tolerate the CPAP and they need to be intubated, they get intubated. That's just one example. Same with our trauma patients, if we need to intubate a trauma patient and transport to Albany. Now we're getting into the season of no aircraft because of the bad weather. So now our transport times to Albany are gonna be extended, 30, 40, 50 minutes, depending on weather. And it's a long time to have a patient where you're trying to maintain an airway that you can't maintain on a trauma patient or a critical medical patient.
And this is not inclusive of a single provider RSI program.
Correct.
So this is a backup for the RSI programs that are already out there.
Yeah, basically.
So this will be a second provider. Can we get, at the next REMAC, all the RSIs from all of our RSI programs? How many RSIs are done? That there's QA on each one of those, the proof of it, okay? And that being the case, if we can get all the data from everybody who's doing RSI, how many? And if we can get some follow-up on them, that would be great.
At this point, it's only gonna be GAVAC because I'm still in the educational phase.
I mean, and Dr. Aya spoke to this. It's, certainly the region has access to all of our PCRs, and has access to that data. Again, Dr. I spoke to that, and I still challenge and fight the fact of whether or not the REMAC for RSI is in our protocols. It's already there. I'm not even sure. I can see an SCT situation. If we were gonna come today and say, or someone was gonna come today say, we wanna have an SCT program, I would venture to guess most of you would agree with that. However, I think RSI is a part of that program that is a necessity, and we've argued that point in the past. I don't see how any agency that's following protocols can't do an RSI.
I have to disagree with you a little bit, Tom, because REMAC has the right to look at anything within protocol. And
They
if
do.
they want data on something that's
And they
within
have access to all
protocol,
of that data.
then, no, they
Thank
don't have
you.
access to your QI.
Thank you for bringing that all to us next REMAC. And that being the case, I will change to approve it, but as long as that data shows up, I will back this.
We can easily bring you that data.
Thank you. Any questions, Tom?
I don't.
Thank you.
One thing to dovetail with what Tom was bringing up, when we discussed RSI, SCT 2 years ago, was it? The REMAC declined to take charge of that. After the Education Committee had done a lot of work coming up with possible protocols and ways to handle that. So just to support what Tom was saying on that.
And I'm gonna
was
agree with
kind
that, but I
of-
just wanna make sure
Oh, yeah.
that that backup is there, that there is being good review, that we are seeing how many of these are being done, and that proper patient intubations and care is being overseen.
I would like to see the REMAC take over the whole RSI SAT program.
I think it still falls with the medical director if they approve it and they accept it, but we still have to buy off on it. And I want to make sure we're going the right direction. It's still the medical director's responsibility.
And I agree, and when we talk about the right thing for the patient, let's face it, most of our RSIs are very seldom going to the local hospitals. You know, most of them are going to a definitive care center, Ellis, Albany Meds. And when, you know, Ed speaks, well, if you're going to Nathan Latour, we look at that stuff. We know that if it's gonna take us 30 minutes to intubate and the hospital's 5 minutes away, we're calling the hospital and say, hey, be ready to intubate this patient. But it allows us to give better patient care for the simple fact is if we can control the airway on scene or during transport to that care center that they need to be at, obviously we'll have better patient outcomes.
Thank you for the data.
Okay, the next several items, I'm sorry.
Is it approved? Is Johnstown approved for RSI?
Yes, that data's going to show up. Thank you. Yes.
Yes?
What?
Mr. Les?
Wait, once the data's, it'll be reviewed next day, next month?
Are you approving RSI now for Johnstown, or you're not?
We'll approve it now, but then we'll see the data next month for sure.
Yes. Thank you.
So it is approved as of now, just for the record, is that correct? Yeah, it is approved now, okay. Next items, Skylar Lake Fire District has adopted a municipal CON for ambulance service and will contract with Richfield Springs, and the town of Richfield will do the same thing, and the town of Warren and Herkimer County will do the same thing, and I only mention the town of Warren and Herkimer County, which is not our region, simply because they're contracting with Richfield Springs, which is in our region. So I merely mention this for proper notification to everyone. Mr. Farrell is not here, so he cannot give us an update on the status of the AAREMS BLSFR agency research or agency compliance with research and inspection requests. Do we have any update on the status of ALS agency controlled substances licensing, hospital pharmacy involvement, and current medication shortages?
Yeah.
Yes.
Let me update just real quick on that. The Drug Supply Chain Security Act that comes into effect November 27th. You guys all familiar with that?
No.
November 27th, they came down with a new law that's the Drug Supply Chain Security Act. And what that's going to do is it doesn't affect us a whole lot, but it gets minimums. So they want to track the drugs as they're being distributed. And the fact coming down is if you order from Boundary, you cannot order each. So if you want a single amiodarone, you can't get it. You got to buy a box. So for the smaller agencies, it may be an issue that you can't buy the smaller quantities that you want. You may have to buy a box. How it's going to affect the hospitals, and if the hospital is your supplier, they may give you an each or a single dose of something that you request. In the big picture, those are the people that are going to be affected. With GAVAC or whoever buys boxes of 25 and they use the box of 25, it's not going to be an issue for the most part for you guys. Just keep your eyes on it, know that the law is out there, and if it does change or come to effect, that it's going to affect you guys in the big picture. Just be aware of it and stay on top of it.
Also, you cannot, as say you wanted to, just for example, Cooperstown, Milford, and Cherry Valley wanted to work collaboratively, and Cooperstown buys the drugs. You can't then give them to Cherry Valley or sell them to Cherry Valley and Milford because you are not a pharmacy and you cannot dispense drugs.
You can't buy the box of 25 and split it between 3 agencies. That's
I didn't
illegal.
think you could do that now.
You never could.
No, you can't.
No, you can't. But the idea is if you've got to buy a box of 25 and you run 10 calls a year, you can't do that. You can't split it with your neighbors.
Okay, thank you, sir. And then the final item on the agenda, I'll refer to Dr. Markowitz by all means, the status of protocol update training statewide and regionally. And Dr. Markowitz sent me a rather lengthy email this morning, early on, so I didn't have a chance to make copies for all present, but I did have a chance to make copies for the doctors here, thanks to the Holiday Inn's copying service. So I'm going to ask Dr. Markowitz to take the lead on the discussion if you would, sir.
We've got some copies to pass out. With the New York State BLS protocol rollout, you guys know that as of December 31st, everybody has to be up to date on their BLS protocol. My thought was to make it a little easier on Phil in the region, that as of December 15th, we sure would like every agency to accomplish it and send a letter saying that it is, that they are done. And that way Phil could send a gentle reminder that if an agency has no idea that they're to be doing the updates, he can send a reminder onto each agency. So as of December 15th, everybody forward a letter that the agency has accomplished it. As of the 31st, you, of course, by New York State, you were offline. Also on the sheet is, and Phil can hopefully include this in the minutes, the Vital Signs Academy access and how to get into that for the update. Next thing on there is the patellar reduction and the training on that. There's a video out. Would probably be, I guess, the best access into that. Patellar reduction isn't that common out there in the field. If there's any concerns, to go ahead and splint it in place and transport them as you always have been. If there's the idea that is this a patellar reduction or is this a knee dislocation, you do not want to mess with a knee dislocation because the docs need to know it for the risk of dissection of the popliteal artery. If it's absolutely a patellar reduction, you're confident in it, and you've watched the video, feel comfortable with it, you've been trained appropriately, the reduction's a great way to reduce pain in your patient. Please do a motion. Oh. So next up is the acetaminophen and ibuprofen. It's now in the protocols for ALS providers. And that's basically, at CMAC, the discussion was that it's you've got to calculate the dose, milligrams per kilogram. And with the med math, they wanted to start this out at an ALS level. So you've got the Tylenol and Motrin. We do need to make a motion that the Tylenol Motrin be added to the formulary for our AAREMS.
Just be careful, there's two concentrations for the Tylenol.
Yes, so the motion update for AAREMS medication formulary to include acetaminophen 325 milligrams for 10.15 milligrams PO unit dose, and there's all the 160 per 5 suspension multi-dose. So we need to be really careful with how many milligrams that we're giving. So the 325 or the 160. So make sure that the training is appropriate for the dosing of your acetaminophen. Also mentioned in there is the limitations on ages. It's all in your protocols, but we need to adopt the acetaminophen. Also, the ibuprofen is 200 milligrams per 10 mLs unit dosing, or 100 milligrams per 5 ml PO suspension. We need to add those to our formulary, and that's all in the protocol.
Okay, do we have a motion second on that, Doc? Okay. Doctors in favor? Adopted.
I'll give you a copy of that, Phil, when we're done.
Just, I don't know why they wrote it like this, but the concentrations are actually the same when you read it.
Yeah.
So 325 per 10 and 160 per 5 works out the same. And the other one's 100 per 5 or 200 per 10. I'm not sure why we put both of those in, because it's making things more confusing.
Just pay attention how you've got it, what your supply is.
You mean read the directions on the side of the bottle and follow them down?
Yes. ALS providers.
Make sure you have your magnifying glasses.
I have.
So, also with the the AAREMS get the regional protocol for the BLS 12 lead. We're following or mirroring Suffolk County. They were the initiators in the 12 lead. And adopt the protocol within the AAREMS.
Are there any facilities in AAREMS that can accept the 12-lead transmission?
Binghamton is one of the ones that can do the transmission. Something we've kind of adopted. There's a few others in the region. I assume up north there's some. You guys transmit your EKGs or just call them with the...
No, we transmit to Ellis or Albany Med, but
Bassett accepts them too.
not to.
Bassett gets them by fax.
By
fax.
Yeah.
They come in as a fax.
So there's been different ways. I know some of the guys have taken pictures and shot them to the dock. There's the transmission capability. And thing that's also is telephone communication. Just reading what Dr. Zoll says at the top of the 12 to give them a heads up. Accuracy, you have to depend on Dr. Zoll. The data is that about 15% of 12 leads, and you call a team in, about 15% of the time there may be an error, and you call the team in for nothing. In the big picture, 15% versus somebody estimated where nobody comes in, we'll deal with the 15%. But I make a motion we just to go ahead and adopt the 12 lead in. And the protocol's in there. Agree?
Yes.
BLS cancellation of ALS. And basically we're gonna come back and reaffirm the previous decision of November 18th, 2004 regarding the BLS cancellation of ALS. And how that was resolved is if an EMS call is presented as a requiring ALS either by dispatch or by state BLS protocol, a basic EMT on scene may call off ALS by contacting medical control if the basic EMT deems ALS is not necessary. And that was resolved back in 2004.
I have a comment on this one.
Sir.
I'm up in Lake Pleasant, speculator ambulance, and it's anywhere from 45 to over an hour to get to the hospital. So if when the call comes into EMS dispatch, a lot of the times, again, last night again, we call for ALS intercept because we are not with the patient yet to be able to tell what's going on. And last night, we called it off. We didn't call the hospital, medical control, or anything. And lots of times we can't. We're in places where we have no contact. Now, during 12 hours a day, we have a fly car, paramedic, and that works where they show up, unless they're on another call, they'll show up for every call, and we'll make the determination at that time. But other times, and I've been doing this EMT for, 7, 8 years, we've always called it off ourselves at that time. And if there's any question at all, we leave it on. It has to be a known thing. For instance, last night there was a question involved, and she signed off. So, but we would take a GAVAC resource and drive it all the way up to the speculator for nothing. So they lose 2 hours on their ambulance, and I'm sure they could use it. So it's a problem for us up in the north.
And it's an automatic, because they don't, so Herkimer County and most of these counties don't use EMD. So it's a simultaneous dispatch. It's not that they're requesting it. It's both agencies are being dispatched based off of a dispatcher's thought, okay, well, this could be, it could be anything. Bleeding, you get there and the guy's bleeding from his finger. But we have to drive 56 miles to get there, only to find that out, and it's kind of crazy.
Well, the idea is if dispatch thinks it, we need to at least get a rig rolling that direction.
Well, that's what we're doing right now. It's just
So
a
if
call-off
BLS gets on
process.
scene, grab your phone and say, your phone, house phone, whatever you can do, and contact med control and see. There's also the out of contact within your protocol. If you cannot contact med control,
Yeah.
you got a procedure to follow right there. That says, I can't get hold of anybody and this guy has a cut finger.
Yeah, in that
Okay,
particular
then-
case, we can't get old ALS to stop them anyway.
So,
Not even through county dispatch?
Well, it depends where we are and all that stuff. We have some holes in
I mean,
communication.
it's rough.
so there's a protocol in place. If you can't cancel them, they're coming anyway. But if you need them, they're coming anyway. So,
The concern is when you have multiple ALS agencies responding, and they're responding hot on back roads.
I agree,
I don't
safety
think that-
first, but
I
how
think
do we,
that is a
how do we
concern.
cancel if we can't talk to
But
them?
it's a concern more that we
Joe.
have to drive 52 miles or 56 miles to find out that we are not needed, only to turn around and drive 56 miles back. It's,
Yeah.
I mean, it seems pretty clear. If you don't have communication, as soon as communication is reestablished, you can call them up.
You're gonna have to. Yeah.
Right.
I mean,
well, but I think what he's trying to say is, we're being dispatched to every call.
Yeah.
And-
Oh, I
and
see.
whether there's
Yeah.
no, you're, yeah, and it could literally be.
25% of the calls, we don't need them.
But I feel like you can still call them off. It's just a phone call to the hospital and say, hey, this is what's going on. We don't need that ALS
If you
unit.
can contact them, you should be able to contact Med Control.
Well, there's just some places we can't.
so I guess my question is, you're questioning Med Control's dispatch of ALS units together with BLS. Is that what you're
It's not
asking?
med control, it's
No, it's
dispatch.
911.
Dispatch.
It's a 911 person
Yeah.
answering the phone.
Yeah, the person answering the phone, the dispatch is both based upon some sort of protocol.
Well, let's do a quick question.
So,
So not
I don't know, not
necessarily a protocol.
There's no protocol, that's the problem.
How many counties have EMD? I mean, is Montgomery, Fulton around EMD? Because Harry is, our dispatchers are EMD trained and qualified. Not that patients don't lie, believe me, we all know they do.
Hamilton is not.
Okay.
Fulton County.
And Fulton County is not.
And I go on a motor vehicle accident,
And Montgomery County won't be until at least March.
and I go on a motor vehicle accident in the town of Hope in Hamilton County, and it takes me 20 minutes to get there with the volunteer ambulance. Let's say I'm an EMT. I have radio contact to contact, maybe I have radio contact, that's a big if, to contact Gabec and tell them no, but I don't have, that radio isn't gonna reach Nathan Tour Hospital Med Control, and there's no cell service there, so Gabec's gonna drive 45 miles for me to go, you know,
I
they cut
can't
the
tell,
finger on the
we can't supersede the
window.
state, obviously. I would suggest, tell them to do a reduced, response, priority 2 or whatever you guys use, until Med Control can cancel.
But if she gets on scene and deems that there's no reason for ALS.
I hear you.
No injuries.
I
know
our problem in Fulton County, our dispatchers and our dispatch director doesn't wanna take the responsibility to decide, you know, if it's BLS or ALS, you know. I know it should be, but they will not do that.
They're gonna be on the hook for it either way.
And I don't know, we're kind of running this issue too, but can you use the county to call the hospital? So if you can't get the hospital, they're the ones that are over dispatched.
Their dispatch centers.
So let's continue with the protocol and the approval that's in place. Contact by phone, contact by radio, Med Control, and stand them down to a BLS level. You're better off having somebody come if you need them than to cancel them and find out you do need them. Or not have them come at all.
We have a pretty good record of making those calls, you know, for the last 8 years, at least that I've been there, so.
Making the phone call
No,
or?
making a call whether we need ALS or not, yeah.
You mean making the decision?
Making the decision to call it off.
Cool.
Yeah, that's what we've been doing.
When you get there or when you hear it?
We
on-
get on scene. We go on scene,
That's what-
evaluate the patient, we call, if we don't need ALS, we call dispatch and tell them to cancel ALS. And that's the way we've been running for 8 years, and it's worked great.
So you're saying you can still do the same thing, but you just gotta call the doctor and let them know you're doing it.
Yeah, that's
And-
a
It's
little
another
bit of an
step.
issue.
The issue is there's sometimes we can't call the doctor where
And there's
we
a
are, where we're
There's
on the
there's
road
already a
or-
protocol in place for that. That if you cannot contact a doctor by any reason or any way, then there's a protocol in place that covers that. Next is the transfer of care policy. And that is also in the protocols and has not changed much. So if you can follow the protocol all the way down within the protocol list, we're reaffirming that one. The AEMT scope of practice, AEMTs can cancel ALS if it is within their scope of practice. So the example being hypoglycemic protocol, so your AEMT, if it's an ALS call, can go ahead and cancel any other ALS coming in because you see where the stop points are going to be the same as your critical care and your paramedic. So if they can handle the call from beginning to end, when they're entirely within their scope of practice, AEMT can cancel. So there's like 12 items where the AEMT covers completely the protocol. Any questions on that one? And I say we adopt that as a...
Can I ask, where can we find the radio or the communications failure?
I'm trying to find it right now.
They had taken it out at one point, and I didn't.
Is it out of protocol?
I'm looking at it.
It's not in there.
Wait, have we taken our regional protocol out?
What's that?
Did we ever rescind our regional protocol on it? Because we had a regional protocol on it.
Yeah, when we adopted the collaborative protocols, I'm gonna guess.
We had one.
And there was usually we tried, but it didn't work. Right, so you do your thing, and I called, they just didn't answer.
We'll look into that and see if they pulled that out, because if it's not, we will adopt it and put it back in.
Thank you.
It's like, where did it go? Okay, thanks, guys.
Thank you, Doctor.
Nothing further, Phil.
Do we have anything else? We have no correspondence which necessitates an executive session of the REMAC at this time. Do we have anything else to be brought before the REMAC?
No, sir, thank you.
Okay. Motion to adjourn the REMAC?
Motion.
11:52 adjourned.
I think it's how they can either do it I guess I'm a little confused, because I did my online protocol.
That's why I didn't really understand, because I couldn't be honest with
I don't think it.
I'm getting stuff.